Hello, everyone. Good morning, good afternoon, good evening, depending upon where you're located. My name is Sara Jane Demy, and I am the founder and CEO of Demy-Colton. And it is my pleasure to welcome you to the 5th edition of the Demy-Colton Virtual Salon Series. As many of you may know, Demy-Colton's mission is all about convening biopharma and digital medicine industry leaders to catalyze change. And indeed, we were in the process of launching a new business development and investor conference here in New York City when COVID-19 interfered with those plans, as it did interfere with the plans of many people around the world. Subsequently, we launched our virtual salon series to bring great content to you and continue our mission of bringing people together. Before we move on to the formal portion of this salon, I want to recognize and thank our BioFuture sponsors who have stood with us during this challenging time, and indeed have broadened their support as our programming has evolved. Today's discussion is different from those that we have done in the past. And in fact, I have to say that we did not plan to do a salon focused on COVID until an issue was presented to us and we determined that we needed to have this discussion as a public service. Today's discussion will focus on the compassionate use of narsoplimab, which has received FDA breakthrough therapy designation for stem cell transplant TMA and IgA nephropathy based on results from a small cohort of patients in Bergamo, Italy. Our three speakers, all leading hematologists who have treated COVID-19 patients on the front lines, will discuss and elucidate key learnings and the clinical results. The therapeutic is being developed by a company called Omeros, a publicly traded company. Please note the forward-looking statement. We want to make it clear that Demy-Colton has no financial interest in Omeros, nor does it have a business relationship with the company. We believe that the information that you will hear about COVID-19, how the virus causes damage, and the similarities between it and TMA is very important. Before I introduce my panelists, please note that at the conclusion of the formal portion of the discussion, around 11:50, we will move to a live Q&A session. The title of today's salon is Lessons from Bergamo, Discoveries in Treating Critically Ill COVID-19 Patients. Before I introduce everybody, I do want to let you know that their full bios are located on our website. And furthermore, we will present abbreviated slide decks. The full slide decks are also available for download on our website. Now, I'm very pleased to start the introductions of our wonderful panelists. First is Dr. Jeffrey Lawrence. He is a professor of medicine in the Division of Hematology and Medical Oncology at Weill Cornell Medical College, attending physician at New York Presbyterian Hospital, and director of the Laboratory for AIDS Virus Research at those institutions. His current research includes a focus on mechanisms of the thrombotic microangiopathies associated with complement activation and microvascular endothelial cell damage in HIV and other disorders, including most recently COVID-19. Dr. Miguel Angel Perales is chief of the Adult Bone Marrow Transplantation Service at Memorial Sloan Kettering Cancer Center here in New York, as well as an associate professor of medicine at Weill Cornell Medical College. He is an internationally recognized leader in the field of hematopoietic stem cell transplantation and cellular therapy. And last but not least is Dr. Alessandro Rambaldi, who is joining us from Milan. He's a professor of hematology in the Department of Oncology and Hematology at the University of Milan, Italy. He is the director of hematology and bone marrow transplant unit at the Ospedale Papa Giovanni XXIII in Bergamo, Italy. He pioneered the integration of molecular evaluation of minimal residual disease in the treatment strategy of adult patients with acute lymphoblastic leukemia and non-Hodgkin's lymphomas. We are honored that all of you are here with us today. Thank you very much for taking your time to join us in this discussion. We will begin with the slide deck from Dr. Jeffrey Lawrence and his presentation. If we can bring that up, please. Do you see it?
No, I don't see it. I'm clicking on slides, but I don't see it.
Can you bring up? There we are.
Okay. So this is fine. This is the first slide. So this is all right. Lessons from Bergamo, discoveries in treating critically ill patients. Next slide, please. My disclosures: I have honoraria research grants, and I have been or I'm on advisory committees to both Amros and Alexion. Next slide, please.
Can you get to slide 3, please?
Yes, I see it now. So this is a slide from a paper that went online in April, was published in print in June. As of this morning, has already been cited 460 times in the medical literature. It's possibly one of the most cited papers on COVID pathophysiology to date. And what we showed early on, using autopsy samples of lungs from 2 patients who died of COVID-19 and live samples from the skin, biopsy samples of skin of individuals that were infected with the corona type 2 virus and then developed skin rashes, was that we stained these individuals for complement components. And what we showed, and the slides keep jumping, by the way. Can you just maintain it on slide 3? Yeah, that. What we showed, and here's an illustration from one of the patients. This happens to be the lung, but we showed identical things in the skin, which is very important because we're looking at the importance of complement to this disease, COVID-19. And people could argue, well, if you have a sick patient, has pneumonia, has lung disease, obviously you're going to see complement deposition. So we also started looking at skin samples, easily obtainable tissues, normal-looking skin, had very similar findings, as has been shown in the figures in this paper. And we found deposition of C5beta9, which is the terminal complement component of the complement cascade. But most importantly, we showed deposition, as you can see in panel E, of MASP2. And the reason this is important is that we documented MASP2 deposition at sites of microvascular endothelial cell injury associated with clotting. And this was the very first time, and the reason why our paper has been quoted so much, that we showed that this is a disease involving clotting in the small blood vessels leading to lung damage. Also, other people now, the Chinese have shown similar microvascular injury with complement deposition in the kidneys, because kidney failure is also a problem in these diseases. And then we also showed it in skin to show that this is a systemic problem. Along with this, both in this paper and in a paper that we have in preparation demonstrating similar findings in 20 more patients, we showed activation of inflammatory components and obviously activation of the clotting system with high levels of D-dimers in these patients. And so this is a disease that involves 3 important pathways: complement, coagulation, and inflammation. Next slide, please. So why am I focusing so much on complement here? Well, one of the things is 2 things. First, in the slide here that you see, and this is looking at, again, a lung case. This is a second case in our series. We showed co-deposition of virus spike proteins along with complement in the damaged microvessels. And we knew from studies in mice that were done about 10 years ago using the COVID virus type 1 spike protein, that it can directly bind to MBL, which directly binds to MASP2 to activate MASP2. So we have a biologic reason in the mouse why injury in the mouse was associated with MASP2, because the virus itself can directly activate MASP2. And here we showed in patients that, again, co-localization of complement with MASP2, and that's a very important finding. It also tells us something about the importance of the virus and how long this virus may be important. Or can we stop thinking about the virus after the initial infection? And is it really the thrombotic disease, the continued complement activation, and the inflammatory disease that are causing pathophysiology? And the reason that this became so important to focus on was a critical study that was done, again, in mice, where they showed if you took a normal mouse and infected it with a mouse version of the coronavirus, it develops weight loss and acute respiratory distress syndrome, just like in humans, and dies. But if you knocked out complement components in these mice, either genetically by knocking out C3 or with an antibody they used against the C5 component, they were able to protect those mice from severe lung injury, and those mice didn't die. But when they measured the level of virus in these mice, this is the important part. The normal mice that died had 1 million copies per ml in their lungs and in their plasma. The mice that lived, because they knocked out complement, had 1 million virus genomes in their plasma and lungs. So it did nothing you don't have to do anything to the virus. The virus did its dirty work. It's now we're focusing on the complement system. Next slide, please. And I mentioned something very important that's going to be a theme in this webinar, and that is the interaction of the complement system with the coagulation system with the inflammatory system. And why, if you shut off just one of those units by individual drugs, like a drug against IL-6, the most potent inflammatory component of this disease, or a drug against clotting, like heparin, they don't seem to work. You really need to attack all of the processes. And the reason I'm talking so much about MAST2, and a focus of this presentation is on MAST2, because MAST2 interferes with more than just MAST2 in the complement system. Because MAST2 is also known to activate prothrombin, which, if you look at the lower right-hand portion of this slide, is very important for initiating the coagulation component. MAST2 can also interfere higher up in the complement stream, because inflammation is such a critical part of what we're seeing in COVID-19, and yet you need to block those components of the complement pathway, meaning C3A, which you can see in the lower left-hand component, and C5A, which you can see in the lower middle component, because C3A and C5A are the anaphylatoxins, the pro-inflammatory components of the complement pathway that are causing a large part of this disease. And luckily, by interfering with MAST2, you knock out not only that pro-inflammatory part of the cascade, but also can interfere with the coagulation cascade. And that's a critical theme in terms of what we're doing. Final slide. This is from a paper that was published in June from our lab, and it's not looking at COVID-19, it's looking at patients that had thrombotic microangiopathies, TMAs, related to either transplants or genetic deficiencies in components, proteins that can regulate the complement pathway. The reason I'm showing these data is that we've shown in this paper that MAST2 levels are very high in patients with these transplant-related thrombotic microangiopathies and HUS-type thrombotic microangiopathies. And when we took microvascular endothelial cells, here we use the skin, and I mentioned before that we showed in our COVID patients that the skin is a particularly sensitive to COVID involvement. And we measured an enzyme named caspase 8, which is the first part that gets activated when you're killing a microvascular endothelial cell by a process called apoptosis. So we took plasmas from patients, acute TMA plasmas, dumped them on these microvascular endothelial cells from humans, showed that we could activate those cells and cause their cell death. And then we gave 1.2 micrograms per ml, a clinically relevant level of narsoplimab, here labeled ORMS721, and was able to block that activity in the vast majority of these plasma samples. And currently in our lab, we're doing the same thing using plasmas from our COVID-19 patients. So in summary, the complement pathway is incredibly important to the pathophysiology of severe COVID-19. The complement pathway is incredibly important because it can be directly activated. MAS2 can be directly activated by the virus itself. But once that happens, you set up this kind of insidious cascade among coagulation, inflammation, and complement. And if you don't block all of those pathways, you're in trouble. And we know that from people who try to intervene individually with just an anti-IL-6 drug, individually with just high doses of heparin. And what we really need is to attack multiple components. And by interfering with MAS2, you can do that. And I will stop there.
Thank you so much. Thank you so much. I do have one question that I want to ask you right now before we move on, which has come in again from our audience. You mentioned that a key component of the pathophysiology of COVID is thrombosis. It's seen in the hearts, the lung, liver, brain, and frankly, throughout the body. Can anticoagulant therapy be effective? I think I know what your answer may be.
Right. So numerous studies are ongoing trying to find out what are the appropriate anticoagulants and what levels do you need to use. When we compare patients that had ordinary, typical ARDS sitting in the ICU, they had much less of these coagulation problems than COVID-19 patients did. So there's something special about them. And the literature is full of papers showing that if you use the standard low molecular weight heparin prophylactic regimen or therapeutic regimen, the standard unfractionated heparin regimen, either prophylactic or therapeutic, there are still clotting consequences. And we have a paper that it was just accepted in Thrombosis Update, the online journal of thrombosis research, where we showed that individuals on high levels of heparin still continue to clot the filters that we're using in their dialysis treatments. There's a paper that was published in May out of Paris showing that 28 of 29 patients with COVID that were put on dialysis machines clotted their filters, despite the fact that they were on appropriate anticoagulation regimens. And in the front page of the New York Times in early May, a nephrologist is quoted as saying that you guys have it all wrong here in the government. You're all trying to buy respirators. You're going to find out that we're going to run out of dialysis machines before you run out of respirators because of the fact that the clotting was happening in front of our eyes. And this has become a popular thing. I've done seminars on this for Voice of America. I was featured on CNN talking about this, Operation Smile. I'm in the September issues of AARP, for those of you old enough for that, and the Smithsonian Magazine this month talking about the clotting problems related to COVID. And just using anticoagulation regimens, at least the way we currently do it, is really not answering the problem.
Okay. Thank you. Thank you for that. And another point that I think we should just underscore is that there is no correlation between the severity of the viral load and the disease that we see in COVID-19.
Right. So I mentioned mouse studies, but a paper published in May from China, a very large study, looked at the viral load levels in patients with mild symptoms, that is a cough, a little bit of fever, and then it got well. Moderate symptoms, that is they may need some sort of oxygen support but weren't on ventilators, or severe symptoms in which they were on mechanical ventilation. And they measured viral loads in these patients. And what they found out was there was zero correlation between the level of virus in your body and how severe your disease was. So they had individuals in their cohort that had just a little bit of a cough of a fever with 1 to 10 million viral copies per ml, and they had people on death's door with 10,000 viral copies per ml. No correlation, which goes along with the mouse studies, 1 million if the mouse lived, and 1 million if you died, because you needed to interfere with the complement system. And it also tells us something. This is supported by the failure of the remdesivir studies. Very disappointing. But you could have predicted it from the mouse studies done almost a decade ago, and certainly from the new information from humans. The virus comes in, unless you clear that virus very early on, and perhaps remdesivir and other drugs given within a very short window could help. But at the moment, there's no evidence that it does very much at all. And that goes along with the pathophysiology from both the mouse models and measuring the virus directly in humans.
I mean, it doesn't do any good when a patient becomes severely ill if it's not given at the initial onset of disease?
It may have some effect in terms of decreasing a number of few hospital days. That's a very minor impact, and it had zero impact on whether you lived or died.
Okay. Thank you very much, Dr. Lawrence. We'll now move on to Dr. Perales. So if we can bring up his slides, please, and we can begin his presentation.
Thank you. I'd like to start off by acknowledging the presentation of Dr. Lawrence, who I think really set the landscape for us today, and also illustrates the knowledge gaps that we have in this field, and particularly as this was a fast-moving pandemic, particularly as it hit New York earlier this spring, that the treatments we had available and the treatments we implemented were not necessarily grounded in strong science, but just what we had to do empirically. So to move on to my presentation focused on the stem cell transplant patients, these are my disclosures. And among relevant disclosures for this presentation are the fact that I do serve as a consultant for Omeros. Next slide, please. And so the first point I want to make is that there is a lot of similarities between what I see in my typical practice, which is transplant-associated TMA or TA-TMA, and a multi-system organ disease, which can affect the lung, as well as what we have seen in COVID-19 affecting the lung. And this is pictures of thrombotic events in vessels on the left from a paper by Sara Jane Demy, who's at Cincinnati Children's and has done a lot of work in TA-TMA. And on the right, a recent publication from Spain, from Pamplona, looking at an autopsy series of 10 patients with COVID-19. Next slide. And this is a paper from MSKCC that was published a few months ago in Nature Medicine. And this basically looks at the number of cases diagnosed with COVID-19 at MSK, which is the largest cancer center in the Northeast. And you can see here from March through May, we had a number of cases who were presented, almost 1,000 patients diagnosed with COVID-19. On the right, you can see the curves of hospitalization, ICU admissions, and deaths. Next slide. And in this study, we looked at risk factors for hospitalization as well as for severe complications. And one that stood out was the presence of having a hematologic malignancy. All of the patients in this series were patients who were treated for cancer. And so cancer in of itself did not come out as a risk factor here, since everybody had that. But having a heme malignancy was certainly a risk factor. Next slide. And then we focused more carefully on the transplant experience. And this is data which is done primarily by my colleagues Gundren Shah and Susan DeWolf, which the slide here says under review, but I actually got the email this morning that our paper was accepted to a Journal of Clinical Investigation, so this paper is now accepted. And what we identified was 77 patients who received either an allogeneic transplant, an autologous transplant, or CAR T cells, and then were infected with CAR T cell. And this is probably the largest single center series to date when it will be published. There were several take-home messages. Among the 77 patients, unfortunately, 18% or 14 patients died. And this was most commonly seen in patients who had active disease, meaning relapse after their CAR T or transplant. But that the patients who had resolved disease, meaning they were still in remission, actually did quite well. And the mortality rate in those patients was around 20%, which is similar to what we saw in the general population in New York. And you can see illustrated here in green are the patients who did well. So over half the patients did well. And then in the other colors are the patients who either had ongoing COVID issues at the time of data cutoff, or in red, the patients who actually died as a consequence of COVID. We didn't see any clots or issues of dialysis. Sorry, no strokes or issues of dialysis, but we did see a number of patients who developed clots as a result or during their treatment for COVID. Next slide. And so what I want to switch now is to the issue of transplant-associated TMA, which is a disease that we deal with more frequently prior to the pandemic. And as I mentioned earlier, this is a multivisceral disease which affects multiple organs, and these are just histologic illustrations of some of the organs that can be involved including the kidney, the lung, and the intestines. Next slide. And this is a different version of the complement cascade that you saw a little bit earlier from Dr. Lawrence. And here again, illustrating the fact that MASP2 is an early event in this cascade in the lectin pathway as opposed to the classical pathway, and that inhibition with narsoplimab is effective at targeting MASP2, but also many of the downstream effects in the complement cascade. Narsoplimab is an investigational fully human IgG4 monoclonal antibody. It binds to MASP2, and MASP2, as I mentioned, is the effector enzyme of the lectin pathway of complement. And it leaves the classical pathway intact. So this is an important drug in this space. And then the other thing is, as you heard earlier from Dr. Lawrence, it also interferes with MASP2-mediated coagulation. So you're targeting both the complement sort of inflammation pathways as well as coagulation thrombosis pathways. Next slide. So TA-TMA is a critical issue in our transplant patients, and the incidence appears to be increasing over time based on the types of patient we're transplanting, as well as some of the drugs that we're using in the conditioning regimen. And so Merus has now conducted a pivotal trial. This is a single-arm open-label study. And initially was started as a phase 2 trial, and then furthering discussions with the regulators in the US and breakthrough designation for narsoplimab was converted to a pivotal trial. And the protocol specified that patients would receive narsoplimab once weekly for at least 4 weeks. Next slide. This is the primary endpoint for the trial. And I think this is a very important endpoint because it's focusing both on laboratory markers as well as organ function. So I think in many instances, we sort of focus on, does the LDH decrease or the platelets improving? But ultimately, the patients succumb of complications related to organ dysfunction and infections. And so the primary endpoint in this study captures both an improvement of laboratory markers as well as organ function and transfusion freedom. Next slide. So looking at the response rates in these patients, the study accrued 28 patients, and of those 23 actually completed at least 4 weeks of therapy. This is a complete response rate. And so that means these are the patients who had normalization of their laboratory data as well as a resolution of their clinical organ dysfunction. And you can see that the response rate, the complete response rate is 54% in the whole cohort of 28 patients and 65% in the patients who completed at least 4 weeks of treatment. And this is a very high response rate in these patients. Having done transplant now for a number of years, with almost 2 decades of experience and having treated many patients, unfortunately, with TA-TMA, we often have very few options to treat these patients. And importantly, when we look at the survival of these patients, you can see this is a 100-day survival. In the study, 68% of the patients were still alive at 100 days, and 83% in the protocol treated patients. And if you look at the patients who responded, it was 93%, 14 out of 15 patients were still alive. So I think this is really very important data for TA-TMA. The company is now in discussions with the regulators about a potential approval, but I think that this data here is also very supportive of the data you're about to hear now in patients with COVID who also received narsoplimab. Thank you.
You wanted to speak to this slide, Dr. Lawrence, Dr. Perales?
No, I think were there any specific questions about this slide?
No, not necessarily. Okay, I thought we had not gone over that. So, for clarity, we understand that TA-TMA is increasingly recognized as an endothelial injury syndrome. Do you consider COVID-19 to be an endothelial injury syndrome?
Yes, I think that there are a lot of similarities between the two syndromes. And I think you heard from Dr. Lawrence's work and from the data that he showed us earlier that there are a lot of similarities between the two. And so I think that MASP2 pathway is a critical event in both of these syndromes, and the ability to target it with the drug is going to be critical to improving the condition of patients. And I think similar to what you see in COVID-19 is that once the insult has occurred due to the virus, it's not a matter of getting rid of the virus. I mean, I think that's important as well, but it's the fact that patients react differently to a similar insult of virus and then develop this, complement-mediated, MASP2-mediated vascular endothelium injury, which ultimately leads to a lot of the clinical complications. And we see exactly the same thing in transplant. TMA can be precipitated by certain drugs or infections. And then even if you take the drug away, the most typical drugs are the drugs we use to prevent GVHD, the calcineurin inhibitors like cyclosporin, tacrolimus, or the rapamycin inhibitor, sirolimus. Even stopping the drug, some of the patients who develop TMA, it just takes off, and taking the drug away makes no difference to the outcome. So once you set the cascade in motion, that original insult, even if you're able to take it away, just like you saw with the virus may or may not be present. The insult is the triggers there, and we have to figure out how to fix the problems related to the vascular endothelium injury rather than just remove the insult.
Okay, that does generate or begs a number of questions. Let's move on right now to Dr. Rambaldi, who was, I think you were probably among all of us, immediately on the front lines before anybody else. And so why don't we move on with your slides, and you can tell your story about how you were brought into the thick of things in Bergamo, Italy.
Thank you, Sara.
You're welcome. Can we bring up the slide?
Next slide, please. These are my disclosures, and in particularly, I serve as an advisor to Omeros for the development of narsoplimab in the context of TA-TMA. Next slide, please. Yes, Bergamo was the epicenter, I would say, of the Western country outbreak of COVID-19 disease. And exactly in February 23rd, we documented the explosion of the disease in our city. At the very beginning, as a hematology, I was not involved directly during the first week of the outbreak. But soon, my colleagues from the infectious disease department, from the intensive care unit, and from the pneumology department called me asking, why are these patients thrombosis? And this was quite an unexpected finding. And so this was the reason why the hematologist was asked for an advice. And so the dramatic severity of the disease led many patients to die very soon in all of these departments. And so we took the decision to move immediately to the autopsy room and to investigate the reason why this patient had this vascular complication. And the picture was quite dramatic. We documented a severe, extensive thrombotic event in the bodies of these patients, in the lung, in the heart, in the brain. And so it became clear that an endothelial damage was developing in these patients. And so we started to look at some biological markers who could give us some insight into this vascular damage. And taking some advantage from our experience as transplanters, we put our attention to evaluate the number of endothelial cells in the peripheral blood of these patients. And what we found was that the number of circulating endothelial cells in these patients was dramatically increased, as we saw some years ago in the setting of graft-versus-host disease, in which the immune-dependent attack leads to the detachment of the endothelial cells from the blood vessel. Next slide. So this was strikingly suggesting that COVID-19 disease was playing severe damage in the vascular structure. And so we thought that the narsoplimab that we were investigating in the setting of TA-TMA could have a good role in this setting for a couple of things, a couple of reasons that has been already alluded to. And one is the direct complement activation of the MASP2 and the lectin pathway. And second, for its ability to interfere with the clotting procedure and the conversion from prothrombin into thrombin. So I call Dr. Demopoulos to investigate the possibility to test this drug in the setting of COVID-19 infected patients. Next slide. Because indeed, as time goes by, we were facing and we were realizing that the similarities and the parallels between COVID-19 and TA-TMA were strikingly similar. There was the activation of the lectin pathway and leading to the endothelial cell damage. This was true both in COVID-19 and in transplant-associated microangiopathy. And in both diseases, the damage was involving multi-organs in both type of patients. Next slide, please. So we launched this compassionate-based treatment program in which we set very simple entry criteria. Don't forget that in those days, we were roughly in a war scenario. So we decided to offer this limited availability of the drug only to patients with very severe lung insufficiency, respiratory failure. And so the entry criteria was simple. The patient had to be in CPAP no more than 48 hours. So an early intervention in very severely ill patients. And what happened in this small series of 6 patients was that the clinical condition rapidly improved. And as you see in this slide, the yellow bar indicates the need, the patient were in CPAP. And after the beginning of the treatment, the blue bar, the drug was given twice each week for a maximum of 8 doses. The respiratory failure improved. And in the end, all patients could move to low oxygen flow, that is the blue bar, and finally being discharged. I'd just like to draw your attention to the fact that at least in 2 patients, the thrombotic complication affecting the lung was absolutely dramatic. And all of these patients, as per hospital guideline, were under prophylactic treatment with heparin. Despite this fact, the vascular complication was dramatically severe, and in these patients, the treatment with narsoplimab led to a rapid improvement of this condition. Next slide. We had the possibility to measure the initial marker of endothelial cell damage, the number of circulating endothelial cells. And as you can see in this slide, in all of these patients from baseline, after 2, 4, and 6 doses of narsoplimab, we documented a significant decrease of the number of endothelial cells. There is one particular case I would like to emphasize, this one, which was the first one, in which after an initial decrease, the number of endothelial cells rose again. And this was the reason why we prolonged the treatment with narsoplimab for 2 additional doses for a maximum of 8. And the number of endothelial cells after the restart of narsoplimab treatment dropped again to a normal level. Next slide. There are other biological markers that documented and corroborate the therapeutic activity of narsoplimab in this patient. Here you see the graph of the behavior of LDH, CRP, IL-6, and IL-8 level from the baseline throughout the treatment with narsoplimab at the end of the treatment, suggesting that the ability of the drug to relieve the endothelial cell damage can come first compared to other immune-mediated attack that in the end leads to the increase of the different cytokines and inflammatory proteins. Next slide. Next slide, please. And finally, I just like to present the behavior of transaminase, and most importantly, the D-dimer. We were able to track the D-dimer in 4 patients during treatment. And as you can see from the right panel of this slide, the D-dimer was going down during the treatment, and in this patient, the level was normalized after 25 days. Next slide. So the possibility, the ability of this drug to interfere with the hypercoagulation problem that is present in these patients is documented by this slide. This is one of our patients, patient number 4, who at the beginning of his disease developed severe lung thrombosis, thromboemboli problem, as documented in the left part of this CT scan. And as you see, during and after a few doses of narsoplimab, the lung rapidly improved, and the vascular problem was significantly resolved. So, next slide. This is my last slide that leaves you the fundamental message that we had the possibility to treat a limited number of patients, but in all of this, we had the result of a clinical resolution of the dramatic respiratory failure, and we had evidence that the hypercoagulation could be downregulated and normalized by the treatment with this drug. And we have biological surrogates supporting our conclusion. And so in the end, the clinical results are in keeping with all the pathophysiological pathway that Dr. Lawrence presented today. And once again, the clinical pictures that we observed in our patients emphasize the similarities between the COVID-19 disease and what we see in TA-TMA patients after allogeneic stem cell transplantation. Thank you for your...
Thank you for your sharing your knowledge and your experience with us, Dr. Rambaldi. A question for you. You treated 6 patients with narsoplimab, and they all regained their health well enough to leave the hospital. What are the sequelae that they're suffering from, or are they?
Yeah, after the end of the dramatic outbreak of the acute phase of the disease, we are now documenting a number of long-term sequelae in this patient. This is again related to vascular problems that remain in the lung, in the brain, and the heart of many of these patients. So this is likely to be a severe problem for many of our patients, even when the viral infection is completely resolved, but the pro-inflammatory cascade that is induced by the viral infection at the beginning, and it's self-maintained on time, and we desperately need treatment that can shut off the hypercoagulation situation and the hyperinflammation condition that is triggered at the beginning by the viral, but then is self-maintained.
So is there anything that you see or that can help with that right now? Is there anything available to address that?
Yes, I think that the observation that we can have a drug able to interfere with the beginning of the inflammation and with the induction of the hypercoagulation state should be further investigated in a number of patients that is remarkably high, and who desperately need an effective treatment in the long-term follow-up.
So is narsoplimab being considered for that?
I would be very happy to consider narsoplimab for that and to move on and to keep going with this treatment for the long-term sequelae of these patients. Yes, definitely.
Right, as we were chatting before we began this session, we are hearing more and more urgent recounting of people who have recovered from severe COVID, but who are still suffering from the long-term sequelae that you mentioned, including, I think you've seen patients, and perhaps Dr. Perales has seen patients that appear to have dementia or Alzheimer's as a result of their battle with COVID-19. Dr. Perales or Dr. Lawrence, do either one of you see other treatments? How are you helping your patients that have recovered right now? Can you?
Right. So that's in the literature. One of the things that Cornell has started at New York Hospital is a PIC unit. PIC stands for Post-Intensive Care Unit Syndrome. This was established before we ever heard of COVID because individuals who are on long-term mechanical ventilation, presumably because of other issues that are going on with getting inappropriate oxygen amounts to the brain, will develop problems. That unit became overwhelmed for a while because of how long COVID patients needed to be on ventilators, and the fact that it was much more intense than what we're used to seeing in the standard ICU patient coming off a ventilator. And one report was that some of these individuals had dementia far exceeding what we used to see on patients with typical ARDS coming off a ventilator, and there was a statement made that it looked as bad as cases of at least moderate Alzheimer's disease, and how long that will work is unclear. I live in Greenwich, Connecticut. We had a mini outbreak there related to the whole Biogen thing in Boston, and one of those individuals was on the front page of our Greenwich Times newspaper saying that he's been out 6 weeks and he still can't think. And this
Right.
is the captains of industry. So it's a big deal here, and we don't really know the pathophysiology of why it's so much more intense in those patients than in your standard ICU mechanical ventilator patient that's being studied.
Right. I know that various publications have been posting stories, more and more frequently about the sequelae post COVID-19, and even people such as Chris Ploma, I believe, was on CNN the other night talking about his struggle,
Right,
post his battle with it. I'd like to ask all of you, I know we're going to be going on to our questions from the audience shortly, but we did receive a few that I'd like to put to you right now. So one of them came in from Washington, D.C., and the question is, in addition to the detailed clinical pathology that you discuss, can you describe treatment options that you have evaluated, other treatment options that you've evaluated and their pros and cons? Why don't we go with you, Dr. Lawrence, first, then to Dr. Perales and
Right. Well, we at Cornell have been part of a variety of studies, and you may have seen recent releases on the fact that most of them haven't worked. So there was the recent announcement from Sanofi and Regeneron that their IL-6 inhibitor, saralimumab, didn't work, and not only that, may have actually increased the number of deaths and increased the number of pneumonias associated with COVID by blocking IL-6 alone. So that is of no use. Roche typically also has another product, an IL-6 inhibitor. That didn't work and has also failed trials. Gilead has a program using remdesivir and tocilizumab, which we've also used. And there the problem is tocilizumab doesn't work. We know that from the Roche trials. And I just mentioned before that remdesivir is in 3 large clinical trials, very, very little effect. And pathophysiologically, we know why it shouldn't have much of an effect. Recently, there was a study, the Corona study, that showed that use of ACE inhibitors or angiotensin receptor blockers had no impact on this disease. And you've heard, with a little bit of controversy between the NIH and the FDA, that it appears that convalescent plasmas have very little impact. So most of the stuff that we've been looking at has not had a major impact on the pathophysiology and the progression of this disease.
Right. Dr. Lawrence, do you want to add, sorry, Dr. Perales, do you want to add anything?
Yeah, I would second those observations, and similar to what you heard from Dr. Lawrence at Cornell, we tried all of the above. I guess one way to think about it is the good news is that this data is coming out quickly, and hopefully we'll learn lessons and move on from these drugs, all of which have failed. The bad news is all of these drugs have failed essentially. And so there's no data to support most of these drugs which have been used and unfortunately continue to be used at many centers that are currently dealing with patients. And I think the other point that he made, which I think is an area that really needs more investigation, is that the patients who survived spent weeks, if not months, in the ICU or an ICU step-down type. And I'm sure that New York City now has an overwhelming number of patients at different hospitals who are occupying these beds. Part of it is because no nursing facility or rehab facility will actually take them. But we really don't completely understand why these patients are not recovering and why they're requiring this pretty intensive care. And so I think there's a lot of work to be done there, a lot of work to be done on the therapeutic side as well, in terms of developing novel agents. And I think the data you just saw from Bergamo is probably the most striking data that we've seen. When you put that side by side with, convalescent plasma, the IL-6 studies that have failed and so forth, it's pretty striking.
Dr. Rambaldi, thank you. Dr. Rambaldi.
We also have been involved in many different studies looking for active drugs. I would say we must be very careful to draw any final and firm conclusion about the results. I mean, the major concern is that we have treated different patients. So the difference between patients might play a role in the evaluation of the results. In our limited experience with narsoplimab, we try to define simple but very consistent data to set the beginning of the experimental treatment in very severe patients. Having said that, I think that it is clear that the new treatment must be designed on the basis on better understanding of the pathophysiology of the disease. And so this should be the guideline to develop future treatment. The other thing is that the disease has many different phases during its course. There is the initial phase. And I can say that in Bergamo, we did not understand at the very beginning many aspects of the disease. For example, we were pushing the pressure of the ventilators remarkably high, and this induced the damage of the lung tissues. And this, because we didn't know that the main problem was not on the alveoli, but was in the vascular structure of the lungs. And the same is true in the long term. We must understand why and the many patients remain severely affected by the long-term sequelae. And so the new treatments must be based on this better knowledge of the pathophysiology of the disease.
Right. I think you just pointed out, another point. I think most people have it in their minds, in particular lay people, that this is quote unquote similar to the flu. I think we've determined that that is not the case, and that it's also a pulmonary disease. And I think all of you would probably agree that it's a disease of the microvascular system. Would you agree with that?
No, I think that's totally important. We've heard about kidney disease. It's something we're very interested in studying. We've heard about brain sequelae. And something very important, Dr. Rambaldi treated 6 patients, but Dr. Perales has treated many more with a similar kind of TMA, just in another setting. So we're not only talking about 6 individuals that have received anti-MAST2 therapy, we're also talking about a larger population with maybe a different insult. It's not a virus. It's maybe a drug or radiation or something else, but a similar pathophysiology in terms of microvascular injury and thrombosis, and with responses in both, I think, are important to remember.
Right, that's a really important point to make. Dr. Perales, do you have anything that you would like to add to that?
Yeah, I think the 2 lessons that we've learned from this pandemic is, one is the incredible international collaboration in terms of knowledge sharing. And so the point that Dr. Rambaldi made about ICU management, ventilator management, very quickly this type of information was disseminated among networks of ICU docs and other physicians treating COVID patients, so that we quickly adapted our clinical management to take these things into account. And then the second point is, I agree with Dr. Rambaldi that we do not want to overinterpret a small case series of just 6 patients, however dramatic the responses are. But I think, as Dr. Lawrence said, you have to put it in the context of our understanding of the biology of these pathways, that this is actually something that we understand better now that we're targeting the pathway, and then put it in the context of the broader experience that we have in T and TMA that is very supportive in terms of data, response rates, and safety. And so I think you have to put the whole story together, where you have a similar, injury pathway, an understanding of the biology, and a drug that specifically targets that biology.
Right, and the pathway is the lectin pathway?
Yes, exactly.
And that's the same thing that you find in TMA. Yeah. We are really, really late on time, so we're almost ready to go into the Q&A that we have that is really getting very busy there. One last question that came in prior to this from a reporter. How does the work, what you're doing, apply to the pharmaceutical developers in terms of therapeutics, diagnostics, and/or vaccines? That's a really broad question. I don't know if we can answer it in 1 minute, but I think to date we haven't necessarily found the answer other than in one particular therapeutic. Who wants to tackle that? Dr. Lawrence, you look ready.
No, it's just you're right. I think the pharmaceutical industry hasn't paid that much attention to the complement system. There are very few products out there. I think what we're learning from this epidemic is how important parts of this pathway may be. And right now, the narsoplimab is the only inhibitor we have of the MASP-2 pathway, and it seems to be very effective. I think I think more people may want to get on board.
Yeah, I thank you all for this. And, as I said, when this was brought to our attention, we thought it was really important for us to have this discussion. I, in particular, know a number of people who are recovering from COVID at different levels, people that were mildly ill, who were very ill. And I think, from my point of view, looking at the disease load that the world is bearing right now because of COVID-19, it's really imperative that we find solutions that will help address the short-term and the long-term issues of COVID-19. It's a devastating disease any way you slice it. I thank each and every one of you for being on the front lines and working with patients and coming here today to share your knowledge. We will hold you on for a few more minutes. I know you all have clinical practices, and I think, Dr. Rambaldi, we're postponing dinner a little bit later.
I can wait.
I know you're very kind. You're very kind. So this concludes the formal portion of our session. So for those of you who have a tight time deadline, we are now going to move into the Q&A portion of our discussion. As I mentioned earlier, we have the full slide decks available for download on our website. We also have everybody's bios and relevant publications available on our website for download. I thank all of you for providing that background information for our viewers, our audience. We do want to, again, before everybody, the big group leaves, thank you all. Thank our sponsors for sticking with us through this. Our response to COVID has been moving forward and trying to bring more knowledge to people about therapeutics and therapeutic development in the world. So now, I'm going to hide you while I go in to look at some of the questions that we have gotten. There are a lot. Everybody is, see if we can answer the questions, even post this if we can't get to them all. So let me go through this. So I have one question, and I'm going to have to hide you because I can't see it completely. Several mAbs have failed to demonstrate clinical benefit in pulmonary inflammation through phase 2 and 3 trials in COVID-2 hospitalized patients, such as IL-6, which I think we've talked about. It appears several mAbs have MOAs that are too far downstream in the immune cascade to provide a benefit. What can you say about that? What does that say about narsoplimab?
Well, I think everything that we've said would agree with that statement. That is, that we know the beauty of having something that works further upstream is you don't have to wait till you activate complement, you break out C3A, you break out C5A, you then induce IL-6. You want to stop that way before all that happens, and that's why forget about making a cocktail of anti-IL-6, anti-IL-8, anti-IL-17, anything else you want to think of. Hit something in a much higher level of the pathway.
Yeah, and the follow-on, the balance of this question is, should narsoplimab and its MOA receive more generous government support to further elucidate this? And I think we probably would all say a great yes to that, correct?
Yeah.
Okay.
Yes. And I would also add, if I can, that the specificity of any drug developed in this field and the lack of remarkable side effects is something that is of paramount importance in the setting of a treatment with severely compromised, often elderly patients with other comorbidities like diabetes, hypertension. And so we need to test and to develop very well tolerated drug. And these drugs can be only those who have a specific mechanism of action with the capacity to interfere with the pathophysiology of the disease.
And that's a very good point, because we do have an FDA-approved drug, eculizumab Soliris, which is an Ultomiris, its cousin, which is approved for the treatment of a TMA related to AHUS, and we've all been talking about TMAs related to AHUS. But the issue is that works against C5, which is much lower down in the scheme than MAST2. It does not interfere with the clotting pathway the way an anti-MAST2 drug would. And there's a requirement, if you take that drug, that you have to be vaccinated against Neisseria, and many people, particularly in Europe, have to take prophylactic antibiotics for the life on the drug, and that's not true with narsoplimab and inhibition of MAST2. You don't need to take prophylactic antibiotics. You don't need to be on special vaccinations.
Yeah, I mean, speaking further to the use of eculizumab in TA-TMA, we've looked at our experience, and the issue we've had with the drug is, vaccinating somebody against Neisseria when they're post-transplant, often on immune suppression and steroids, and with no immune system to speak of, that vaccine's not going to work. So we give the vaccine so we can check the box, but really we don't expect it to work. So patients do have to be on prophylaxis. And while the drug has worked, what we've seen is a lot of infectious complications. And it's different in the children, where the results seem to be more promising. But I found it very challenging in adult patients to give that drug because of the 3-month survival rate.
Okay. There is one question that I think we probably addressed in some way, other than the 6 COVID patients treated successfully with narsoplimab in Italy. But you also say that they have sequelae, the patients that you treated, Dr. Rambaldi. Is there a current study being done to evaluate the use of narsoplimab to treat other COVID-19 patients? Is there a study underway now?
No, there are no studies ongoing. The 6 patients that we treated do not have so far severe sequelae, despite their initial presentation of their disease. So this is something that is that adds something to our clinical observation. But for sure, the many other patients not treated with narsoplimab do have long-term sequelae. And for those patients, we must develop good clinical trials in the near future. This is an urgent need. We must set up clinical trials in a short time, because they need it. And so we need the availability of active drugs in that setting, short term.
Yeah, I completely agree with that. I think when you think about the resources that have been put into some of these other agents, IL-6 blockade, hundreds of patients, convalescent plasma, thousands and thousands of patients, we really need resources to support a trial with narsoplimab to sort of confirm the data that we've seen in the preliminary setting.
Okay. I think, I think the urgency is really quite clear. Here is another question from a contact in Europe. And it focuses on the complement biology. You mentioned that MAST2 acts upstream in the complement biology. Would you say that a C1 inhibitor would be more effective than a C5 inhibitor in C19? I think, Dr. Lawrence, that's for you, in COVID-19 patients.
Yeah, well, sir, I don't know about C1q inhibitors. it's certainly upstream of any of the other things you've talked about, not of MASP2.
C1 inhibitors.
Right.
C1 inhibitors. Mm-hmm.
Right, C1 inhibitors. But I know of no data at all with C1 inhibitors in any of the TMA diseases that we're talking about that have shown efficacy. So I just don't have a comment.
Okay, Dr. Perales?
No, I don't have a comment on that. I haven't seen any data in that regard.
Okay.
I cannot comment.
Can I comment?
No, I cannot add anything to that.
Okay. Okay. Again, Dr. Lawrence, this is for you. You said that a drug would need to hit all three different MOAs. Do you have any data which suggests that one pathway is more dominant than the other, or are they equally dominant?
I think the data comes both from the animal studies that I mentioned. They just hit one pathway in the animal, and it meant life versus death. That is either knocking out complement or using an inhibitor. And then I think it comes from the individual trials that, try to knock out IL-6, ineffective, try to give superdoses of heparin, ineffective. So I think, I think it's basically the coalescence of that with the information that we know that the virus itself directly activates MASP2. So it's not like this is all theoretical.
Okay, and when you say the complement system, what we're talking about, basically the only therapeutic that's currently available for that is narsoplimab.
Right, as well as mentioned before in eculizumab, but as we've mentioned, eculizumab works much further down the pathway, and I think Dr. Perales had some important points to talk about that. Okay.
Dr. Rambaldi?
Yeah, I think that the data that we have just emphasize the importance of tackling the complement activation in this disease. And so once again, I think that the more specific and the more selective is your drug, being at the same time able to interact not only with the complement activation, but also with the coagulation pathway, that is the better condition and should be followed up with great attention.
Okay, a question has come in. Can you identify patients who are at risk for developing severe COVID-19 early on in the infection stage? Is there any way to do that?
The only biomarker, there's no great way to do it. The biomarkers that people have tested the most have been looking for activation of complement, coagulation by levels of D-dimers. And as Dr. Rambaldi pointed out, in his patients, the high levels of D-dimers suggested that something bad is going to happen to these individuals, and particularly the trajectory of D-dimers, that is, that it's going up in the face of whatever else you're trying to do for the patient. We need other biomarkers. Our lab is looking at measuring MASP2 levels themselves, as we've looked at in our TMA patients. We're also doing biopsies, skin biopsies, in patients with this disease that we're considering for other therapies that are not getting better on all the therapies that are being used, to see that by demonstrating MASP2 deposition in these patients, as I showed you in our initial publication, that they might be good candidates for this. But again, this requires more attention. Dr. Rambaldi might suggest that we look at endothelial cells circulating in patients. If levels of those going up, maybe they should be intervened, because we'd like to intervene earlier rather than later. The peculiar thing about this disease is, in the vast majority of patients, you get the fevers and the cough and the respiratory difficulties, and then it gets better. But in some patients, between about days 8 to 10, you hit a wall and bad things happen. It's like you're jumping off a waterfall, and there's not for nothing has the complement cascade been labeled a cascade, and the coagulation cascade been labeled a cascade, because you hit a wall and you no longer can control it, and then bad things happen. And if we could try to intervene in that window of, who's going to get better versus who's going to go on to need other therapies, that would be a wonderful group of patients to treat, rather than have to wait when they're on the ventilator and everything else is happening.
Okay. Another question has come in. Well, there are actually many questions, which I can share with you all later. We're, going into 60 questions here. This particular questioner notes that you're not obviously urging everyone to take this particular drug. drug, narsoplimab. But is there a subgroup of the population that you all think would be, most treatable, who should get it? And I think you're probably also encouraging other research to be done on the complement system in order to have a bigger variety of therapeutics available. Hence the public service announcement. So, Dr. Rambaldi?
Yeah, I think we must select very wisely but very accurately the entry criteria for any patients with an experimental drug. The experience with the recovery trial run in the UK with dexamethasone is on thousands of patients clearly indicates that the results of such an experimental treatment can be very different if you offer this treatment to a mild or a middle or a very severe patient. And in that setting, only a subset of patients got a benefit from the steroid exposure. The same is true for any other drugs. What we can say is that narsoplimab was given to a limited number of patients, but they were all severely compromised and in the absolute need of an early intervention because their respiratory failure. So I think that to understand the effectiveness of a drug, we should set precise entry criteria, and we must have biological surrogates to monitor and to get a quick answer to the effectiveness of the drug. This was the case of narsoplimab, and we hope to keep going on this.
Right. I'd like to ask Dr. Perales, and we'll get to Dr. Lawrence to speak to that because you were treating patients with TMA.
Yeah, I mean, I think what you're hearing here is that we have clinical predictors of patients who will get sick and who may require admission or even escalation of care. And we now have a drug that biologically makes a lot of sense, and there is exciting preliminary data in patients with very advanced stage of the disease. What we desperately need is sort of the biomarker that helps us better guide, the therapy and predicts the patient who you admit to the hospital because they need supplementation oxygen. Is that patient the one who's going to do well, or is it the patient who's going to fall off the cliff, 4 days after admission? And ideally intervene in that patient when the cascade is taking off before you start to see, the whiteout on the X-ray or the CAT scan. And so I think, the way you would want to proceed is to build on the work that Dr. Rambaldi has done with his colleagues in Bergamo and sort of, validate that further in those patients. But, even more importantly, try and sort of move it up in the line of treatment and see if, a understanding of the biology and developing biomarkers can actually help prevent that progression before it even takes place. Because that's where the biology is leading us.
Right. We need people. From my understanding, there's limited availability of this particular therapeutic to go into for potential use in clinical trials. So we're hamstrung on that regard, but that doesn't make the need any less urgent. So, Dr. Lauren?
What you've seen is the drugs that we've used in COVID have been the drugs that we had in the pharmacy. Everybody's doing CAR T cells, so everybody has tocilizumab in hand. And, the study report from China that tocilizumab did something, and suddenly, in Spain, you couldn't get tocilizumab for CAR T patients because they'd used up the whole national stock of tocilizumab. And they had used up all the stock of siltuximab. They were emailing me from Spain as, what do you use next for CAR T if you run out of tocilizumab and siltuximab? Have you tried anakinra? So it's sort of, very little data, a lot of anecdotal data, and these were not patients treated on studies. And so I do think we need, well-designed clinical trials, but we need support for those trials. And if you have a drug that biologically makes sense, that we have, safety signal in TA-TMA, that's a drug that we should move forward. And, even in transplant, this is a drug that we desperately need because the patients that are with TA-TMA don't have great options today.
And that's what this drug is on track with the FDA to be approved. So
that's an area where we desperately need, good treatments and early treatments as well.
Yeah,
we are facing the paradox that narsoplimab has been developed for an ultra rare disease, TMA, and now can be active in a disease that is affecting hundreds of thousands of patients around the world. And so this clearly should be a matter of attention for the regulatory agency and people that has the possibility to decide how to develop this drug.
Right, and in addition to the pharmaceutical companies and others that need to pay attention to the complement system to help build up the armamentarium that we need to fight such a disease. Gentlemen, we've gone to 12:20, and I'd like to ask you for closing comments. I'm sorry to have kept you so long, but indeed this conversation is really important. I hope our audience has stayed. So if I can go around the circle, we'll go to you, Dr. Lawrence, first.
Well, I'm glad that we've established with this audience the importance of complement in this disease, but not only that, the importance of the interplay between complement, coagulation, and inflammation. I hope we've left the message that it is much more important to interfere with all of these pathways rather than to try to kind of whack them all in terms of individual cytokines or individual anti-clotting products. And with the development of a drug that can inhibit two of these pathways directly, that is MAS2 activation, that the virus directly activates, and activation of the coagulation system, as well as prevent the formation of the two pieces of the complement pathway, C3A and C5A, that activate IL-6 and the other pro-inflammatory components, you have a really promising agent, pathophysiology-based, and with Dr. Rambaldi's studies in humans and Dr. Perales' studies in other types of TMA, very similar to the COVID pathology, a real rationale to move forward with this in clinical trials, to my mind, a much greater rationalization than we had to move forward with a number of the other anti-inflammatory products that have been used and failed.
Okay, thank you. Thank you so much, Dr. Lawrence. Dr. Perales.
Very difficult to follow up on that summation by Dr. Lawrence. I think he really hit it, all the key points. I think, the biology is there. There is early clinical data in these patients. There's more extensive clinical data in the transplant patients with TA-TMA, and we desperately need drugs in both those settings. And I think this is really a drug that we would like to see explored further and eventually approved, so we can actually, give it to the patients who need it.
Thank you. Thank you, Dr. Perales. Dr. Rambaldi, last but certainly not least.
Yeah, thank you. But my comment is just a human comment. I mean, the experience of being a physician to treat COVID-19 was a very tremendous experience. We saw so many patients dying, and we faced the lack of knowledge that we had at the beginning. We were just a white page in front of the disease. We had some very confused idea coming from China, and then we realized that this was not a flu-like syndrome. And so the speed of understanding was very rapid, and the positive thing was the interaction within the scientific community. And I will also say with the pharma component, because it was very important for us that we were desperately seeking for some remedies for our patients to have some attention. And this was the most important experience I can had in those days, very sad days. And so in the end, it turned out that we have been able to produce some biological and some therapeutic new ideas in the field. And this is of great importance.
Okay, thank you. Thank you. As I said, thank you all. I think also speaking from the human point of view, we know the damage that COVID-19 has done to our population here in the States and populations everywhere. I can't even think about how this is being dealt with in, seriously underdeveloped countries where you have very little access to healthcare. In particular, when you think that we're in a developed country and you're in a developed country and we don't have answers, for this and are struggling with it. So the need is absolutely clear. I want to thank each one of you for joining us, as I've said multiple times. I want to thank our sponsors, since we are going to be signing off, for supporting us. A recording of our discussion will be made available in about 4 hours on our website as well. So there will be a reference piece there for people to come and see it. And we'll also be producing a transcript of the discussion for everybody. Again, thank you very much. It's almost 12:30, and you were kind enough to stay with us longer than we anticipated that you would need to stay with us. So thank you very much. We're signing off now.
Thank you, everybody.
Thank you.
Bye. Bye all. Bye all. I hope I see you on the other side of the story in a better. Thank you.